I have a next section we'll talk about is antibiotics. So we move on to the next section. We're going to talk relatively quick, not too long. We want to talk about antibiotics. So we have been talking about these bacterial infectious disease. What is really the message to do the treatment? Obviously is antibiotics. So we want to have this lecture to talk about what is antibiotics and give you the overview what it is. So basically we're going to rely on the slides at the beginning, then we'll talk about something a little bit detailed later. So when we talk about the antibiotics, there is a definition, is a chemotherapeutic agents. What is that? Is synthetic chemicals administered to people or animal for treating disease. Then they comes out with something which is called antimicrobials and antibiotics. So here is something we want to still draw on the blackboard to let you understand. Antimicrobials. This is going to be chemical synthesized. This is most of the time is chemical synthesized. Let's say lactic acid, and let's say citric acid. But it could also be natural. For example, essential oil. You have a cinnamon. That is one of the antimicrobials from the natural. Antibiotics is belonging to antimicrobials. This belonging to antimicrobials. Then what is that? Antibiotics. This is a metabolic ingredients. Or we say chemicals from one microorganism to kill or inhibit another microorganism. This one microorganism, most of the time, is yeast and mold. It's a fungi. It's a eukaryotes. And the other microorganism, this is most of the time, is bacteria. So a good example will be penicillin. Penicillin comes from penicillin. Generate the penicillin. Okay, so that's a definition of antibiotics. Chemical introduced by microorganisms. Now, of course, it's in a very low concentration. It's most of the time is microgram per ml. So it's a very low concentration. It's a kill or inhibit bacteria. Remember, kill we call bacteria cyto, and inhibit we say bacteria static. Okay, we have those two terminology talk about that. Tetracycline from Streptomyces, but there is an exception. In the except of sulfur drugs. Sulfur drugs, long time ago, it is manufactured, chemical manufactured, to prevent the enzyme distribution during the system. to prevent the metabolic process of the bacteria. Usually it's only inhibit the bacteria, so it's a bacteria static impacts. This is a chemical synthesized. It is not it is not naturally existing. So we say it is just an exception. Sulfur drugs is an exception. Other than that, most of the other antibiotics is all the metabolic ingredients or chemicals from microorganisms. Okay, so that's something we want to be emphasized here. This is a history for the antibiotic therapy. In 1912, Paul Irish discovered salvacin. This is used to treat syphilis. So start from 1912, people start to find some chemotherapy for the syphilis. This is right now we no longer talk about these things called chemotherapy. Chemotherapy we usually talking about is cancer treatments. For the cancer treatment, we don't talk about these things anymore. But by the time the syphilis using salvacin is chemotherapy. In 1929, Fleming discovered the penicillin. That's the first antibiotics happened in the world. And then in 1944, Burgee and Westman discovered streptomycin against tuberculosis. By the time before that, lots of the people, especially European country, people died with tuberculosis because there is no antibiotics. 1944, streptomycin created against tuberculosis. 1947 is chromamycin. This is the first broad spectrum antibiotics. But I want to tell you one thing, chlorophyll, we don't use that anymore because it's going to be significantly damage the bone marrow system. It will be significantly to decrease your immune capability. So no longer use that at all, unless in a life-threatening situation. 1950 to present, people are using antibiotics a lot. And I want to tell you one thing, later on when we talk about exam 3, talk about genetics, we also going to mention, this is a very big milestone in the medical area. Remember, in 1912, there is a Spanish flu. People died, millions of people died. That lasted about 10 years. Later on, why people survived? Because after about 30 or 40 years, people developed antibiotics. That's targeted for the bacteria. So right now you have a coronavirus for 3 years already. It's going to be lasting maybe many years. So people have a wishful thinking, which is this virus, this disease could let people develop effective treatments for the antiviral chemicals. So hopefully it will be another milestone of the medical history, microbiology medical history. Okay, so just want to let you know. Start from 1950, antibiotics has been widely used. However, it's used too much. Therefore, we have another big issue coming out is antibiotic resistant. And a big good example is MRSA, methicillin-resistant Staphylococcus aureus. And I'll tell you one thing more than that. Tuberculosis, for example, 90% of the tuberculosis, the pathogen has already been resistant to the antibiotics. So that's become a major issue. And not only in the medical area, in the food microbiology area, the antibiotic resistant gene has been spread from everywhere. And that could be in the environment, retransformation, conjugation, transduction, and go to the food supply chain. So it's also a risk. And I want to tell you one thing. I did a research a couple of years ago. It's very simple. I just collect a sample. In the WVU area, the Ruby Hospital area, we get the water sample, get the field sample, get fresh produce sample. You just plate it. On the agar plates, put a disc of antibiotics, tetracycline, rifampicin, vancomycin. You're going to find the resistant bacteria. It's so popular and so universal. So I just want to tell you one thing, antibiotic resistance is a big issue right now, okay, because people are using way too much. This is an example of antibiotics. So you have a bacteria grow there. Is that right? A smear. You have a penicillin there. You see the transparent zone. That is, which means they're curing the bacteria. It's a bactericidal impact. So we want to talk about some of the general characteristics of the antimicrobial drugs. Selective toxicity. What this means, that means the ability of the drug to kill or inhibit a pathogen, but damage host as little as possible. We really want the antimicrobials or antibiotics have minimum impacts for the human being, which means the side effect will be much less. However, it cannot be avoided, especially the antibiotics, the target is not cell wall. If it's a cell membrane system or protein, then more or less will have some side effects for the human being. We'll mention later on. The second thing what we talk about is therapeutic dose, that the drug level required for the clinical treatment. This has to be done, is a test for the MIC. To determine MIC, minimal inhibitory concentration. This is the one you have to do a tube test to do that. So that's a therapeutic dose. Toxic dose. What do you mean the toxic dose? Which drug level at which drug becomes too toxic for the patients. Then the therapeutic dose is usually the therapeutic dose divided by the toxic dose. The index is usually the toxic dose divided by the therapeutic dose. And we want this number to be the larger the better, because we want the therapeutic dose is the smaller the better. Okay? That's called the therapeutic index. Selective toxic, the ratio between toxic dose and the therapeutic dose. Side effects, undesirable effects of drugs on the host cells. Most of the antimicrobial drugs or antibiotics, it could be only target a few bacteria or pathogens. We call it a narrow spectrum. So for example, some of the antibiotics only target for gram-positive or gram-negative. Some of the antibiotics will target many different pathogens. It's called broad-spectrum drugs. And we also mentioned about cidal agent, which is killing bacteria, static agent. It inhibits the growth of the bacteria. Okay, next we would be very quick talk about the several methods to testing MIC, minimum inhibitory concentration. This is the first one we will do in the lab. We'll talk very briefly right here. So what we do, on a bacteria agar, this agar is very special, called the molar-Halton agar. A very special agar, not neutral agar. We're going to add the bacteria there. Okay, so let's say we're going to spread the bacteria using cotton swab. Now, the concentration has to be fixed, which means it has to be in the same level. We need to meet 0.5 McFarland standards. What is that? This is basically is around 10 to the 8th CFU per ml. Now the bacteria prepare in the physiological cilia, 0.9% of physiological cilia. Then we have this pressure. So we press the button. All of these pressures, there is those tubes. And those tubes inside, there is a lot of the disc. These discs containing antibiotics. They usually looks like this. If it's penicillin, we write P and write 10. What is P? It's penicillin. What is 10? Microgram per ml. Now, how do we determine the concentration? This is established by the American Microbiology Clinical Association. They established that number. So once we have a bacteria there, we press a button. The disc will be disposed on the surface. So let's say this is 10 for penicillin. This is 5 for ampicillin. And this is maybe 10 for vancomycin and this is like 20 for tetracycline, T or T, tetracycline, for example. Then we will do is about 35 degrees Celsius incubation for 24 hours. We got to look for the transparent zone. You will see more or less there are some transparent zone there. Sometimes it's huge, sometimes it's small. Then what we're going to do is use a ruler to measure the diameter of this zone. Let's say this zone is about 12 millimeter. And then we have to compare standard table. Does this number fit 3 different categories? Which category it is? It could be resistant, it could be susceptible, it could be intermediate. You have to look at the table. So for example, if the resistant is 15, intermediate is 17, susceptible is 20, you get your inhibitory zone is 12 millimeter, which means this bacteria is resistant to penicillin. Therefore, this concentration you cannot use. You may need to use a higher concentration, or you may have to pick another antibiotics. Okay, so this is something we will do in the lab. Another thing we also want to mention, the terminology we're using here, we call it susceptible. And we don't call it sensitive. Why? Because as a human being go to taking antibiotics, we have to do is a skin test to see the allergy. Some people are allergic to the antibiotics that they cannot use. At that moment, we will say somebody is sensitive to penicillin. However, we want to differentiate from the bacteria standpoint. So for the bacteria, we always say susceptible. So we say E. coli is susceptible to penicillin, or Salmonella is susceptible to ampicillin. So be careful, the words, the terminology here is we are using a little bit difference. Okay, so this is called a Kirby-Boer test, disc diffusion test. We will do this in the lab, it's lots of fun for that. This is the E-test. What is the E-test? Is you have a test strip there. And then you're going to put a bacteria there. So, of course, the concentration is from high to low. Usually is twofold degradation, diluted. And then you got to find the number which is at the intersection, which is between the cloudy area and the transparent area. That number is MIC, is minimal inhibitory concentration. That's one what we need. And this is called a semi-quantitative test, is an E-test. Usually in the medical areas they use a lot. But really in the lab, what we should do is a more accurate number is using tubes. So what they do, they prepare different type of the tube, all the same volume, and start from 16 microgram per ml, do a twofold C area dilution. Now, of course, you need a control, which is no bacteria. We call it a negative control, because we need to make sure the solution is sterilized. We also need a positive control, which means the tested bacteria is really growing. So after we are doing this twofold C area dilution, we're going to inoculate with organism A, organism B, organism C. Let's say this is E. coli, this is Salmonella, this is Listeria. Then we add them, the same population, and then we do the incubation. After incubation, we want to see is the first tube, which is transparent. Because the control, the lower concentration of the antibiotics, of course, is not going to kill bacteria. It's going to turn turbidity. With the concentration increase, it's going to show transparent. We also want to see is the first transparent tube. So here, for organism A, the first transparent tube is 0.12. The second is 1. The third is 16. If you want to say, if this is a penicillin, for testing those 3 microorganisms, which one is most effective? Which one we should use? is absolutely the penicillin is only work really well for the organism A, because the MIC is 0.12 microgram per ml. These are really too high. We have to reach the 0. Microgram level. Once you reach 1 or 16, which means kind of resistant to this certain microorganism, so antibiotics, so we should pick another one. Okay? So this is something we're going to end up with here. Now, Thursday we do not have a class because of the lecture class, because of the lab exam. So next Tuesday, we will have and finish the mechanism behind the antibiotics and the control methods. Then next week, Thursday, we'll do the review. So this coming weekend, I'm going to put on the eCampus of our review question for the exam 2. Then you can go ahead to do it. Next Thursday, we'll do the review. Okay, so that's the plan.